Okay, is that live? And we gotta start recording.
Yeah. It's not on YouTube yet, though. Right?
I don't see, that's the part I don't.
Oh, yeah, it is. It's
Oh, I want monetization. That is so confusing.
viewer, that's me.
Sweet. Oh yeah. Is everyone here?
No, but
It's fine. We'll get started. Oh, there's most people. Okay.
4 people.
Oh, wow. All right, let's go. Let's go. How's my audio? Can you just make sure I don't go in if I'm getting too loud? Tell me to like
You can be like,
lower your voice. Okay. All right. All right. We've got 4 more people signed up, but we're just going to get started. Sound good? All right. I think we're a few minutes late anyway, so. I see a lot of new faces, so welcome. If I haven't met you, my name is Dan. I'm one of 5 pharmacists here now, which is pretty awesome to say because I only used to be, well, way back when there was only 1 pharmacist. And then I joined the team back in 2010, so then I was the 3rd, 4th pharmacist, and now we've added even another one. So we're growing, which is good. I think what we're doing here is actually fixing healthcare issues and health problems versus just, and this seems odd for me to say this, but as a pharmacist, we're deprescribing medication here and not just piling on more medication. And some of you that have heard me speak before, I think you probably know that about me already, but if you haven't, we're a pharmacy that is trying to find the root cause of problems, and I think with this testing too, I see a lot of nodding heads already. Like with mental health, it's very subjective. There's not a lot of objective data out there to say, are you depressed, are you anxious, do you have OCD, whatever it is. It's just kind of like, if the doc thinks there's enough there from a symptomology standpoint, but it's not like blood pressure or cholesterol where you can measure something, or if you have a broken bone, you do an x-ray. Well, if you have a broken head, I mean, yeah, we can do MRIs maybe, right, and all that kind of fancy scanning technology. I know down in Chicago, there is a place that actually does like deep scans. The Amen Clinic, has anyone heard of? Yep, I see a lot of nodding heads. I've read a couple of his books. We're not going to go that deep into the imaging and scanning tonight. This is kind of just surface level. This is like an entry-level class to neurotransmitters. So, and then what we're doing here, what we've started, and we've had this for a long time, is the neurotransmitter test from ZRT. It came out about 6 years ago, but I was too afraid to talk about it. And so now Monica is like, you should do a talk on neurotransmitters. And I'm like, oh, okay, fine. So here we are. I'll do it. And so there's a lot of crossover for those that are patients here. We do a lot of thyroid, we do a lot of hormones. And hopefully what you'll see tonight is there's a lot of overlap. If you've got thyroid issues and they're not getting resolved, maybe we should look at neurotransmitters. Or if there is a hormone issue, we're still having hot flashes, we should maybe look at neurotransmitters and stuff like that. So we're going to be on the journey of neurotransmitters tonight. Welcome. So as I already said, I'll repeat it, and I get ahead of my slides, so I apologize ahead of time, but we are trying to live optimally. We're not just trying to, every day a patient walks through the door and they show me their labs and, oh, my doctor said I'm normal. All the labs are in the normal range, or it's not high, it's not low, but I feel like crap. What? I'm still broken, even though my doctor says I'm not. So I want you to live optimally. So this is my legalese of saying I'm not a medical doctor, so I technically cannot de-prescribe medication. I could give recommendations to your doctor that says, you know, Mrs. Jones here, she's on 40 milligrams of fluoxetine, let's say, some kind of antidepressant, and I recommend we taper that down slowly. I have a lot of experience in tapering medication, so the one story I shared a few months ago was a patient that was on Cymbalta, and we actually took the little beads out, and I can't remember the time frame, I think it was every 2 weeks or every month, we took one less bead out for her. It took her 2 years to taper off of her Cymbalta. But we can do stuff like that. An easier way with medication, Cymbalta is kind of unique, but there's other medications that we can just turn into a suspension or a liquid, which is a lot easier for the patient to then taper, and then you have a lot of control. Instead of drawing up 1 mil, you draw up 0.9 mils or whatever that may be. So we have a lot of flexibility in helping you taper off medication. So there's that. And then I added this slide in, but anything I'm going to mention tonight is not approved by the FDA or hasn't been. I can't say that anything is going to treat or cure anything, especially like with this test. It's just for informational purposes only, so leave it at that. So, if you want to have I will say if you want to have a personal one-on-one consultation with me, you can call Kelly tomorrow at the pharmacy and schedule that one-on-one. That becomes a different story. But for tonight's class, we're just going to be talking about, you know, things in general. I'm going to skip over this, but this just says we're a PCAB accredited pharmacy. I will say briefly that not all compounding pharmacies are created equal. I get that question all the time of why do you become accredited? Why did you go through all that whole process? What really sets us apart as far as the quality of the product, because a lot of the things that we do in our labs, they're not required by law. Anyone can, I shouldn't say anyone, but any pharmacy can compound as long as they have a pharmacy license in the state of Wisconsin. But in my opinion, I would be very leery of a pharmacy that hasn't been accredited by a compounding accreditation body. So basically, you got to know what you're doing when you're compounding. So topics for discussion. Let's see. Oh, my clicker's not working. There we go. Hopefully, we'll get through most of this. You know, but how did we get into this mental health catastrophe? In my opinion, we're going to go through some physiology. Actually, a lot of physiology, so sorry if I'm going to bore you with that, but we have to kind of get a basic understanding of the physiology because that's how why the testing makes sense. Understanding the players of the game, so there's inhibitory, there's things that excite us from a neurotransmitter level and things that will kind of push us back down. Let's look at that. Last month I did a whole talk on the gut and how the microbiome interfaces with so many different systems in the body. So the GI tract keeps showing up on, seems like every talk that I give. So we're going to look at gut-brain axis and how, you know, how does the gut and the microbiome interface with our brain. There's a whole system about that we'll get into. You know, and then is neurotransmitter testing right for you? I mean, it's not going to be for everybody. So how do we help? You know, I can help you distinguish that. And then, you know, I thought my SSRI will cure me of depression. So. Yeah, I see a lot of shit. No, it's just, it's strictly, well, I got to be careful on how I say this now, but in my opinion, it's a Band-Aid. It's not fixing the problems. Like, you didn't go into the doctor's office because you had a serotonin, or I should say, what's a good SSRI? Prozac. You know, I didn't have a Prozac deficiency, and that's why I'm now depressed, right? So, and I'm not saying that all medication is not needed, not warranted, so I would be careful with that. But I think we need to be doing a better job in the medical community of finding that root cause for the problem. So last month when I did my GI talk, I think we were here for like 3 hours. It's a long time. So hopefully we're not here that long. So I'm going to hold all the I started taking questions during the class, and I think it got out of control. I had to call security. It was a mess, but. So we're going to try at a different format. So try to remember your question. We'll get to it at the end of the class or at the end of the seminar. So I try to ask my employees this every week. We have a huddle at 9 o'clock before we open the doors at 9:30. And I ask them, why are we here? And they're like, well, I'm here for a paycheck. And I'm like, well, you can go to McDonald's and be here, but we're here to help patients. We're here to help you feel better. Hopefully you're here tonight to find out, you know, do you have a neurotransmitter issue? If you do, you know, what can you do about it? We really want to fix the problem. So you can't, once I keep going on these slides and you're sitting down in these chairs, you can't go back. You can't unlearn this. Okay? So everyone's got to be ready. There's no going back. And my clicker is driving me crazy because I got to point it right there. I talked about this in my last class as well, but just so we all know this, like we're living longer. I feel like medicine is keeping us alive longer, and it is. I mean, the statistics show that, but it's coming at a huge cost. I mean, it depends on who you talk to, but in another 20, 30 years, the healthcare system that we have is going to, I think, implode. Like, we just don't have enough money to keep it going the way that it is, in my opinion. It's going to bankrupt us unless we change something. I mean, the cost of pharmaceuticals has just skyrocketed. Even in the 20 years I've been a pharmacist, I mean, it's scary. I mean, I don't even buy traditional, well, there's a few things that we buy from a manufactured standpoint, but the cost is just unbelievable to me. Pretty scary stuff. I mean, I used to buy, when I did work regular retail pharmacy, they had like a 1,000-count bottle of blood pressure pills for like $10. I mean, just, but those days are long gone. And ideally with mental health, how can we reverse chronic mental health disease? Sometimes we can do that. I think with the neurotransmitter testing, I think it's just going to hopefully provide insight for patients and give them just another tool that they can use with their physicians on, at the very least, prescribing the right medication instead of just trial and error, on 10 different things, so to speak. And I found this article interesting, but this was just published last year. Like we're in 2023 now. Like we still don't know what causes depression. I was learning about SSRIs back in the early 2000s, and SSRIs. Patients depressed. Ask them these series of questions. Oh, they qualify to be diagnosed as depressed. We're going to give them an antidepressant called Prozac because we're just assuming that they're serotonin deficient. It's really kind of what we were kind of sold, in my opinion. But we really still maybe don't know what causes depression, which is kind of scary. We're getting better at it, I think, with imaging and looking at different parts of the brain. And are they shrinking? Are they growing? There's that whole, and this is beyond today's class, but like neuroplasticity, where we actually can grow neurons back in the brain, that kind of stuff. So why neurotransmitter testing? I think it can help, and if patients really want to delve into this and get MRIs and brain imaging, knowing what your level of serotonin is versus your GABA, I almost said gabapentin, but that I think will help direct physicians on what medication is going to be best suited for that patient, if at all, possibly. So maybe you take the neurotransmitter test and everything is normal. So then what? Then that's like, now what's wrong with me? It's not a neurotransmitter issue. Based on neurotransmitter testing, practitioners, I just said this, can identify specific biochemical imbalances for each specific patient. So instead of just guessing why somebody might have anxiety, do they have too much adrenaline coursing through their veins? Or is it not even a neurotransmitter, but it's a hormone like cortisol? Is that the problem? So sometimes we can just do this to kind of cross this or check this box that it's not neurotransmitters at all. But it does give us a system to objectively monitor therapy response. So you can actually give somebody an SSRI, but test their neurotransmitter levels before and after and see how that changes. And not everyone's going to respond the same. Maybe their serotonin will go up. Maybe you'll actually push it down. So all kinds of interesting cases I was looking at. And then enhances medical access and advances personalized medicine. That's really what I like. Back in, was it January or February, we did a whole talk on genetic testing. I think more and more of, hopefully medicine goes that way where it does get individualized, so we can actually say, with your genetics, do you methylate well? What's your liver function? Can you actually take this drug? Can you actually metabolize it properly? That kind of thing. So I think this neurotransmitter testing kind of just builds into that. So. Did I skip a slide? Uh-oh. mean, so this is just a short list. This is not all inclusive, but if you have any of these conditions or symptoms, neurotransmitter testing, again, might be right for you, but these are some of the things that we can kind of tease out with the testing that we have available now. So anxiety, depression, chronic fatigue, impulsivity. I'm reading this list out here mainly for those at home, but insomnia, PMS, ADD, ADHD. I get it. It really does sadden me with ADD and ADHD. I've got younger kids now. I've got a fifth grader, going to be a sixth grader, and she has friends already on ADD medication. It's just like, really? It's just, yeah, kind of the world we live in, unfortunately. But addiction, so a great example of that would be like dopamine. We'll talk about that tonight, and that pleasure neurotransmitter. Eating disorders, OCD, panic attacks, sleep disturbances. You might be having, again, too much adrenaline coursing through your veins towards the end of the day. We can now show that and look at that from a diurnal rhythm standpoint. Maybe it's not, everyone comes, well, I shouldn't say everyone, but a lot of patients will come in and say, well, I can't sleep. Where's the melatonin? We can test, this neurotransmitter test will actually test your melatonin level. So instead of, again, just wasting, I hate to say it, but wasting money on melatonin when you have the proper level, let's find the root cause of why you can't sleep. Lack of focus, brain fog, again, this just helps us kind of pull apart the layers of the onion, so to speak, to figure out what's going on with each patient. A lot of this we already do, like I talked about it, we do a lot of testing for adrenals and cortisol. We do a 4-point cortisol test here, which is unique. I do not recommend going to the doctor and just getting a blood test for your cortisol to see if you have adrenal fatigue, because just sticking a needle in your arm is going to raise your cortisol. It's going to artificially just boost up your cortisol. So you're going to give a false positive, so to speak, right off the bat just by that test. So we do a saliva test where you just spit in a tube 4 different times a day. You can tell if you have enough cortisol or too much and at what time of day. The sex hormones, I kind of talked about that woman that has menopausal symptoms, or they'll come in, they'll get an estrogen cream for their hot flashes and progesterone, what have you. And they'll be great for 3 to 6 months, and then all of a sudden their symptoms start creeping back in slowly. And it's usually, I hate to say it, but even like my reaction and the doctor's reaction is, oh, that woman's, their hot flashes are coming back. She doesn't have enough estrogen. But if you go and test her estrogen, she has more than enough. So those hot flashes could be due to something else. It could be, again, neurotransmitters, possibly. It could be a million different things, but there's one other tool in the toolbox we can use to help kind of figure out if somebody is having hormone imbalance. Is it truly hormones or is it something else? And then same thing with thyroid. If you're hypothyroid, you don't have energy, you're cold all the time, gaining weight. Again, it partly might be due to not enough thyroid hormone, but you may not have neurotransmitters that are kicking off the hormone cascade that's involved with thyroid. So, and then heavy metals are in there too. There's a whole slew of issues just with heavy metal testing. I'm not going to talk about that tonight, but we also offer heavy metal testing, and then we can say, do you have too much mercury in your system that is causing your hormone disruption or your neurotransmitter disruption. So we can really start to tie all of this together now with this testing, which is nice. All right, so since hopefully let's get on the same page here. What is a neurotransmitter? Because there's hormones, what do they do? We won't talk about that tonight, but neurotransmitters are chemical messengers. I'm just going to read this off here. So they relay information within the brain and throughout the body. So a lot of neurotransmitters are actually produced in the periphery, outside of the brain. Serotonin is a great example. I love talking about serotonin and depression. Depends on who you talk to. 70, 80, even 90% of our serotonin is made in our GI tract. It's not made in our brain. So that's kind of crazy to think about that. When I can't tell you how many thousands of pills in my retail pharmacy days I've dispensed of SSRIs, of the Prozacs of the world, and who knows if they were doing anything. Imbalances can lead to, again, this could possibly be over or under stimulation, leading to, and we'll get into this, but more physiological or physical symptoms. So just think of a neurotransmitter as, again, just another part of that messenger cascade. And they also interface with the endocrine system too, with hormones. So this is just kind of saying the same thing, but they're chemical messengers used by the nervous system to relay information. They can bind, and this is where it's going to get a little techy or geeky here, and a lot of the physiology, but they can bind to postsynaptic nerves. So you've got, I always think of the electrical system of our house. You've got a light switch, so like these chemical messengers are kind of in the middle by the light switch, and they're relaying information down to the next wire, so to speak, either turning something on or turning something off. But neurotransmitters can also bind to various tissues in the body. They may not just be going through the electrical system of our body, but they actually might be hitting tissues and activating tissues themselves. They're not, don't think of them just in the nervous system of your body. So they can also influence tissues. I said, and this gets into this, just anything that the body experiences, just keep in mind that there's a neurotransmitter involved with that. So all of our senses, anything that we feel, touch, smell, ingest, anything that we hear, there's a neurotransmitter going off, whether we know it or not. So, and again, is it too much? Is it too little? Sometimes we just don't know. I'm going to skip this. I think we all know this, but whether it's your heart beating, whatever you feel from an emotional standpoint, again, there's more neurotransmitters getting kicked off. The other way I think about neurotransmitters too is if they get all bundled up here, I think this is like somebody's IT room in their office building. This is not our building, but I thought this picture was hilarious. But like the signals could be just flying all over the place, up, down, backwards. It can just have a huge mess. And to have a physician in the healthcare system that we have figure this out in 10 minutes and just subjectively say you're depressed, because it's that switch right there that we need to reverse. I just don't think that's practical. So, yeah, there's definitely a dynamic influence of hormones, neuroactive steroids, neurotransmitters, all involved with neurotransmitters. So it's like a neuroendocrine problem. All right, we're going to get into some of the players of the game here. So just think of like two buckets, the way I think of it. There's neurotransmitters that can excite you, get things moving and upregulated, and then there's another bucket that can downregulate things. So from the excitatory standpoint, we're going to go through these one by one, but we got dopamine, epinephrine, norepinephrine. Those are like, I think of those two as just adrenaline, your fight or flight neurotransmitters. We got glutamate, histamine. This is PEA, which is phenylethylamine. Again, these are all excitatory, kind of get things going. And then from the inhibitory standpoint, I think of this side as the brake system of the body. So it helps to slow things down. So GABA, if we have more GABA around, it slows things down. We have less anxiety. Glycine, and then serotonin. And serotonin is very neat. We're going to talk a little bit more about serotonin, but yes, it's an inhibitory neurotransmitter, but if we have enough of it around, it actually improves our mood. So that's a little bit odd to think of it that way, but it actually improves mood. This is just that same list repeated again. Think of the excitatories as turning the switch on, flipping things on. All right, so I'm going to talk about dopamine first. So think of dopamine, the neurotransmitter, as that reward neurotransmitter. So the best example I can think of is when patients unfortunately can get addicted to opioid medication or narcotics, and they get that rush of that feel-good kind of thing. They get a huge dopamine rush. That's that reward center. Or if they're addicted, any kind of addiction, you're typically getting a rush of dopamine neurotransmitter. So it doesn't necessarily have to be medication per se, but dopamine is primarily involved with that, where it just gives you that euphoric feeling, and you're trying to chase that dopamine rush. The problem and this goes for a lot of the neurotransmitters, but the problem with using medications, or I'll use that heroin example, is those receptors, just like hormone receptors, can get burnt out. And so that's why you need a higher dose and a higher dose and a higher to feel that same effect, because Either the dopamine's not around and you're trying to push more dopamine out, or in some cases it's the receptor that's receiving the dopamine, that's like that receptor on that side just isn't working anymore. So dopamine is all over the body, though. It's not, I always think of dopamine typically of just in the brain, and it's not. It's all over in the periphery as well. So keep that in mind too. Like dopamine plays a role in blood vessel control. It plays a role in GI motility. Sodium excretion out of the kidneys. So it's all over the place. Again, I say this is the adrenaline. You know, when you're running from the tiger in the jungle, you got adrenaline coursing through your veins. That's your epinephrine, norepinephrine. That's just kicking things off. It's slowing down your digestion, but it's opening up the blood vessels to your muscles to get you out of dodge, so to speak. So yeah, our fight or flight response. Or when the DEA shows up at your pharmacy, not that that would ever happen here, then your adrenaline goes off. You're like, oh my gosh, what's the DEA doing here? You get really excited, and then you got to calm yourself down. But overall stimulates wakefulness and reduces your digestive activity. Epinephrine or your adrenaline, this is a little bit interesting. So you got an excitatory, you got alpha-1, beta-1. So now we start getting into receptors and a little bit of pharmacology here. If you excite alpha-1 or beta-1, you get blood pressure increases, heart rate goes up. So we have something in the pharmacy world called beta blockers. Is anyone on them? Well, don't raise your hand, but you got like atenolol, metoprolol, all the OL drugs out there are these beta blockers. They're trying to reduce the amount of epinephrine that's hitting that receptor on the heart tissue and slowing your heart down. But there's a whole slew of side effects with that, right? And if you think about it, like if your doctor gives you a beta blocker, are you really overproducing too much adrenaline all the time? That's why your blood pressure is high? I doubt it. It's probably, what's the root cause? Even if you are, why are you producing too much? Because a lot of that adrenaline is coming from your adrenal glands. Are you stressed out all the time? You know what? Again, getting back to the root cause of the problem. I would argue, and I don't have a study to prove this, but I would think the majority of the patients that get put on a beta blocker because their blood pressure is elevated is not because they're overproducing epinephrine. The little bit that they probably are producing, this is the drug that can block this a little bit. So let's just use that. That's the tool we have in our toolbox. It's the best we got. From an inhibitory standpoint, there's alpha-2, beta-2. Beta-2 is found in our lungs. Here's a great example, albuterol inhalers. So it's a beta-2 agonist. This is a little bit confusing, but when you activate that receptor, the airways open up so you can breathe better. But then again, you're overstimulating that receptor, and then that albuterol, you need more, and you need more, and you need more. And then the other problem with albuterol inhalers, if you ever used one, it's not a perfect drug. It'll also rev up your heart rate. And not all the time, but it is one of the side effects with albuterol. I think these are the last three excitatory neurotransmitters. So we got glutamate, and this test, we'll get to this in a few slides coming up, but it's a urine test that tests all these neurotransmitters. We'll test all of these different levels, which is really cool. And it'll actually test, we'll get into this, but it'll also test the metabolite. So when this neurotransmitter breaks down, it breaks into a different product, we will actually measure that metabolite as well. There's different things we can do to help fluctuate that. Think of glutamate as the on switch in the brain. So this decreases sleep, optimizes learning, memory, mood, improves libido. But too much of a good thing is associated with dementia and Alzheimer's. So we've got to be careful with glutamate. Don't get too much glutamate. Histamine increases metabolism, promotes wakefulness, and suppresses appetite. And I'm sure if you heard of like Allegras of the world and the Zyrtex and the Benadryls, the antihistamine. There are side effects with those antihistamines, and some of that is right in here. So if you're taking an antihistamine, you're decreasing metabolism. You're, when I take Benadryl, it makes me tired, right? It increases my appetite, or it possibly can. Now, there are paradoxical reactions, like sometimes you give antihistamines to kids, and they bounce off the walls. So there's always exceptions to some of these things that are out there, of course, but in general, that's what histamine's doing. And then PEA, or this phenylethylamine, promotes energy, elevates mood, regulates attention. Here's where it gets important to see if a kid really has ADD, ADHD. We can measure this now. This phenylethylamine. Do they have too much or too little of that? But it promotes energy, elevates mood, regulates attention. Actually can cause aggression, serves as again a biomarker for ADHD. So we can look at that now and say, hey, does that kid actually produce enough of that or not? Are they really deficient in it? So, and then these are the off switches: the GABA, glycine, and serotonin. So GABA think of GABA. Actually, we've got, and I'm not recommending you go and do this, but you can we sell it as an over-the-counter supplement, neurotransmitter. But think of it as the brake system of the brain. It helps to slow things down. If you take more GABA, less anxiety, essentially. So if GABA function is increased, if you have more, so it seems a little bit like backwards a little bit, but you're increasing inhibition by taking GABA. This improves mood, relieves anxiety, promotes sleep, and again, think of GABA as either the off switch in the brain or the brake pedal. It helps to slow things down. And when you start looking at depression or somebody with anxiety or OCD, you always want to make sure that the brake system of the brain and the neurotransmitters in the body are established first before you start giving them the gas pedal. So you always want to do that. So don't ask me why I put the chemical structure up there, but that's what that is. I will not quiz you on that tonight. I probably used to be able to draw that, but not anymore. GABA synthesis. So mainly synthesized in the kind of like before the light switch, so to speak. It's synthesized in the presynaptic neuron from the precursor called glutamate. So I am a huge fan. I know I'm going off camera now. But I love this stuff for acid reflux. It actually is fuel. This is one of the few things that glutamate does, is it feeds the cells in the GI tract to repair them, and then it helps our soft tissue so our heartburn doesn't hurt as much. I've had one patient that I can remember that has taken this, and then he called me a few days later and he's like, does this cause anxiety? And it can, and I'll show you. There's a slide on that, but anyways, you got to be careful with glutamate. And then, so presynaptic neuron precursor called glutamate, but you need B6, and then there's a dependent enzyme that converts glutamate into GABA. The interesting thing about GABA is and this gets into the gut talk from last month, but there are certain bacteria that we've identified in the GI tract that can actually produce GABA for us. So without the B6, without the enzyme, we actually have microbes that can produce GABA. So we might have anxiety because we just don't have that certain strain of bacteria that we killed off because we had a sinus infection 2 weeks ago, and now all of a sudden we can't calm down, we're nervous all the time, and maybe we just killed off the last few bugs that were producing the GABA in our GI tract, possibly. So got to start thinking about, and there's more and more studies like that going on, not only with anxiety, but depression, and that other list that I showed you earlier. So yeah, I say certain gut microbes, like we know of a couple of them, but there's probably more players involved, considering that there's millions of different microbes in the GI tract. We probably only know like 1% of what's going on down there. So these are the names. These are classes of different microbes that have been identified, but there's different species below that, so to speak, that we still need to tease out which bug is helping us and which one's not. GABA is one of the most popular signaling molecules in the central nervous system. The entire class of pharmaceuticals called, let me say that again, the entire class of pharmaceuticals called benzodiazepines increase GABA receptor function, so it helps calm us down. So these are your Xanax of the world or your Valiums of the world, which I dispensed thousands and thousands of pills, unfortunately. And again, I'm not saying that they weren't necessary, but again, I think we could have done a better job of helping that patient, again, get to the root cause of their anxiety to help calm them down and not just overstimulate this receptor. The problem with these is they're also very physically addicting, so then when the patient doesn't take their Xanax or their Valium, then their anxiety goes up even worse, so then they're physically addicted to it from the neurochemical side of things. So that, and then to taper off of that can take a very long time. Sorry, I just got ahead of myself. But physical tolerance is thought to be the removal of the receptor site in the brain and also changes gene transcription. So there's a few different things that these benzodiazepines are theorized in doing that, in my opinion, can be more problemsome than what it's worth to take these medications, in my opinion. So, and what I mean, so like this removal of the receptor, so like think of your benzodiazepine attaching to that next neuron, and then you get that calming effect. Well, that next neuron, the receptor on that next neuron, fades away. Just, it's gone. The cell's like, yeah, I'm not going to produce that receptor anymore. I'm getting tired of seeing Valium, thrown at me, so that I'm just not going to produce that receptor. So that's one proposed theory out there. There's a few studies that try to prove that. Glycine has a dual role. So again, we're in the inhibitory category still. As a neurotransmitter and an amino acid as a building block of tissue in our body. Improves sleep though, calms down aggression, serves as an anti-inflammatory agent as well. So you can you can get, well, I don't have it in stock, but you can get just pure glycine as an amino acid. Sorry, my phone is on. All right. We don't deal a lot with glycine, but it's on the list, so I just want to briefly talk about it. Serotonin. Again, I think most of us know about serotonin as that kind of happy, good, feel-good neurotransmitter. Contributes to feelings of calm and well-being, eases depression and anxiety, supports sleep, decreases appetite. Preliminary studies show that certain strains of, again, here we go back into probiotics, might improve depression symptoms. So we're looking more at the GI tract. Again, as I said before, again, depends who you talk to. 70, 80, 90% of serotonin is made in the GI tract. There's certain bugs that are helping to produce that serotonin. We might just be able to give somebody a probiotic to help calm the symptoms of their depression or their anxiety. And again, I just mentioned this, but it's this whole gut-brain axis. There's a lot more going on in the GI tract than we give credit for. That's probably influencing our brain. And we've heard it, well, our enteric nervous system, which is the network of basically electrical fibers that wrap around our GI tract, is kind of that second brain. And again, I think we all know this, but the gut mirrors really a lot of emotions, almost every emotion that takes place in our brain, how we're feeling, and that type of thing. So there's going to be a lot more research done on that. I have a whole book. If you're nerdy like me, I'm about halfway through this, but this is a great book by Emmer and Mayer on the whole gut-brain connection and the dysbiosis that's causing a lot of mental health issues in our country and really all across the world, I think. So I've had patients come in, multiple courses of antibiotics, and then mentally they just say they feel off. They don't feel right. I don't feel like myself anymore. So, and it's subtle. Some of these things, we have to be really in tune with our bodies sometimes. So, proper integration of millions of nerve cells, regulating contraction, secretions. There's a whole network of again, electrical wires wrapped around our GI tract. If the gut nerve system is misfiring, patients often experience symptoms that could affect brain health. So we just have to make sure we're not overlooking the GI tract when we're talking about mental illness, in my opinion. And then I'm going to skip this slide, but just know that if you, let's just say you have a patient that's taking an antidepressant and maybe it's mildly successful, but they're still not there, but then you know that you have a history of that same patient that's been on multiple courses of antibiotics. That might be that patient where you're like, let's check the bugs. You can actually, with this test, you can see the populations of all the, well, not all of them, but a majority of the good bugs that are in your GI tract, plus the bad bugs, plus it can test for candida. It doesn't test for parasites. I've asked the company about this, but it's just bacteria and different fungus, so different candida species. So this might be something where if I know a patient, again, has a lot of history of antibiotic use, but then they also have developed now, let's say depression or anxiety or ADHD for that matter, I might be going in and testing their, or encouraging them to do a GI test. This is a stool test. But, this is what the report looks like. You get microbe diversity, beneficial bugs. I just talked about this, pathogenic bugs, and then phyla balance. I'm not going to get into all that tonight, but just it's a very comprehensive report, so it can tell you a lot about what might be going on. And this is just a slide I took from my last seminar about, well, antibiotics can cause dysbiosis, stress, cortisol can do that. A lot of medications that are out there can screw up the GI tract, which could then lead to mental health issues. NSAIDs, so you're even just taking ibuprofen every day, or every other day for that matter. My favorite, antacids, PPIs, antibiotics, talked about that. Even just steroids. We have more and more patients coming in on prednisone for autoimmune issues and all kinds of crazy stuff. It's unfortunate. Even allergies. Some patients with this horrible allergies are stuck on prednisone. And then it doesn't help adding all of these, we call them food additives, but they're space alien chemicals, in my opinion, that, these emulsifiers, dyes, preservatives. Do we really know what BHT is doing in our food or in our body? Or, red dye number 40. Yeah. Funny that we call them food preservative. Don't get me started on that. Okay. Food allergy sensitivities, list goes on there. So yeah, this is like, I came across this picture. This is not in my basement of my house, but I'm sure it is somewhere. But we've got to fix the electrical system, at least take the dust off of there. These are some really old switches, kind of need to upgrade to a better circuit panel there. But we got to think about fixing up the wiring of our system, of our brain and our body. So, and then especially the neurotransmitters that are kind of running back and forth through it. So these are just some statistics I found. These are, I want to say from 2014, but 7% of Americans living with depression, 18%, I'm sure these numbers are higher now after COVID, but of the adult population living with anxiety disorders, so that's like 1 out of 5 patients. Mood disorders are the third most common cause of hospitalizations for 18 to 44-year-olds. This one scares me. Top prescribed and top selling prescription drugs, 2014, including antipsychotics, antidepressants, and ADD medication. I've worked here so long, I don't know what traditional pharmacy is doing out there anymore, but we do a med intake for every single patient. Well, at least we give them a if you're a patient of ours, every new patient gets a medication intake, and we have 4 pharmacists here on site. We have one pharmacist that literally just reviews medication intakes, I wouldn't say all day, but a good majority of the day. And we find way overprescribed patients. And it's just our little, one little store in little Brookfield, Wisconsin of the world. It's just so scary to me. Why patients are here for thyroid or hormones, and they're on ADD. I mean, I see it every day, every week for sure. Of women that are on, especially when we serve probably 80% of our patients are women, but on antidepressants and ADD medication for years on end. And I'm just like, what is going on? So scary stuff. Which, by the way, progesterone is a great, I gotta be careful how I say it. I feel that bioidentical progesterone, and there's some literature to back this up, actually quite a bit, but bioidentical progesterone is a great anxiolytic and antidepressant. So progesterone can help. I'm not saying it's a cure, but it can certainly help. Even men too, actually. So women, if you have progesterone at home and your husband's getting like crabby at you, just rub some progesterone on him and he'll feel a little better. Just tell him it's body lotion or something. I don't know. So yeah. Anyways, hormones can definitely interplay with all of this. So let's see where are we at here. All right. So here's what the neurotransmitter kit looks like. Basically, there's it's a pee test. So it's like these little strips that you have to either pee on, or what I propose, because this just happened a couple of days ago where Emily's laughing, a patient dropped her strip in the toilet, and so we had to send her some new ones. But so I recommend peeing into a cup and then dipping the strip in the cup. So yeah, so there's that. But this test, yeah, it's an objective measurement now. We can actually say, just like blood pressure or cholesterol or whatever lab that's out there, right? Your B12 level, your vitamin D level. What is your serotonin level? What's your GABA level? How much epinephrine is coursing through your veins right now? Is that why you can't sleep, or is it some other reason? Maybe it is melatonin. But let's test it now. We can get to the root cause of some of these problems. Yeah, because usually it's just trial and error, and I saw so much trial and error. Like especially when I see some of these med intakes and I see all the allergies. Like some patients are allergic to like 5 different antidepressants. It means they had to try them, right? To be allergic to them, they had to been taking them. So it's like, oh my goodness. So, and as I said before, this is worth mentioning this last point here. This test isn't diagnostic. So, but it gives us insight, and it gives us information. So it does not directly measure neurotransmitter levels. That's important to understand. A lot of the neurotransmitters, like I talked about serotonin, epinephrine, norepinephrine, dopamine, majority of those neurotransmitters are actually made in the periphery. And actually, a lot of them are made in the adrenals. So we have to extrapolate some of this data. So that's important to know, so or to keep that in mind, because you're peeing out metabolites of these neurotransmitters and the neurotransmitters themselves. So it's not like we don't have a direct correlation to what's going on up here between the ears. So there is still a little bit of interpretation that needs to go on. So, yep. And then here's those neurotransmitter cascades. So here's that glutamate I was talking. Here's glutamine. So what was happening with this patient that was taking this for their acid reflux is that was converting right into the excitatory neurotransmitter and jacking him up, and he was bouncing off the walls. So either he had not that all this matters, but these little acronyms in purple are enzymes that do conversion in the body. And then in this kind of yellowish color are different cofactors that help to convert, to make it simple, is like, you have an amino acid that connects to this to this enzyme, and then there's other like vitamins around to help with the conversion to produce whatever it is we're trying to produce. So like maybe this guy didn't have enough B6 in his body, or maybe he had a genetic SNP that this enzyme didn't do very well converting over to the inhibitory neurotransmitter, and when I gave him that glutamine in that bottle right there, it all just turned into the excitatory neurotransmitter. I personally I probably go through one of these a month because I cheat on my diet. Shame on me. Confession time. And I don't have that problem. The majority of the patients do not have that problem, but that's just something to keep in mind there. And not that all of this matters, but we're testing, or when you do the neurotransmitter test, we're testing your glutamate and your GABA, everything that's in this box here, glycine, histamine. And we're testing some of these that aren't boxed in too. I apologize. But